Russ is a nationally recognized expert in TANF and other human services program, having served as a board member of the American Public Human Services Association. I can think of no better guide to help us rethink, reform, and ultimately improve New York State's Medicaid program. Please join me in welcoming Russ Sykes.
Thank you, Paul. Russ Sykes is only a shortfall, and I hope it doesn't show today as operating machinery, so we'll do our best. Paul, I really appreciate the nice intro, and I'm delighted to have old friends and very learned folks who are going to respond to my comments this morning, so I think it's a terrific panel. What I really want to do in this about 20 minutes is go through several slides to give you a sense of what the paper really focuses on, and the first 8 or so of them are really just context, and Paul has already addressed some of that. But let me just show you with the pictures worth 1,000 words kind of approach. This first chart shows you what Paul mentioned with Medicaid enrollees, around 5 million, actually up from about 3.3 million in 2002. 1/4 of all New Yorkers are on the Medicaid program. It's the second largest participation program in the country, second only to California. The next slide really looks at the cost side that we talked about as well. The cost of the program now is, in the latest fiscal year projections, mid-year for this year from the Division of Budget, is now around $54 billion, about half of that borne by the federal government, the other half shared semi-equally between the state and the local counties. And in this state, I think we all know that the Medicaid budget is a very taxing issue for local districts, local counties, often crowding out other costs. New York's overall Medicaid spending is about 13.5% of federal spending nationwide. The per patient spending is about $8,960, second largest in the nation. And just to give an example, just as an analogy as to how big New York's program is, the costs of Medicaid in New York, for instance, exceed the costs of Medicaid in Florida, Illinois, and Ohio combined, just to pick 3 states. One of the things we're going to talk about today, I think one of the main foci actually, is that a great deal of the costs in Medicaid we know are driven by the long-term care side, somewhere over 40%. But the majority of costs, even larger than that, are acute care costs, around 52% of all Medicaid spending, both in and out of institutional settings and so forth. But those acute care costs stem almost entirely from the incidence of chronic disease, which is very disturbing, if you can see from this chart. Some of these numbers are Medicaid-only numbers. The ones with the star next to them are not disaggregated for Medicaid and other health spending in the state of New York. And they don't sum, as you know, because obviously many of these issues are co-occurring as far as chronic diseases. But one thing we can do as a proxy about the diabetes figure, for instance, is we know that if your income is less than $15,000 a year, that you're 3 times more likely to be diabetic than you are at higher incomes. So these substance abuse and mental health conditions often co-occur with chronic disease as well. And this is an area that we just simply have to get our arms around if we're going to control Medicaid spending and have better patient outcomes in the future. Paul also mentioned, and I'm not going to dwell on it, that in spite of the high spending in New York, and this is again an admission and a point of what's being done by the Medicaid Redesign team, is that we have poor health outcomes. Paul already gave you some of them, but we rank middle of the pack overall in health quality and very low in the quality of long-term care and, as Paul said, hospital readmissions. And our access to primary care physicians is actually very poor because of low Medicaid rates and a number of things. So one of the key things that we really need to do, and that the governor is taking on, is expanding the availability of primary preventive care so that we stop paying so much for procedures and start paying more for outcomes that actually bend the cost curve and help patients achieve better health. When the governor appointed his Medicaid redesign team in 2011, his quote at the time was that New York's bloated Medicaid program, which spends more than twice the national average, must be reformed to help our state make ends meet. And you can see what was done in the first year of the governor's Medicaid redesign team, some major efforts to control costs, including a global cap on spending in the Medicaid program under the Department of Health, reduced personal care costs where the hours of billing were out of control and costs were mounting, a 2% across the board spending reduction, some reductions in pharmaceutical spending, and having brought a number of people to the table from many sectors of the healthcare community, a number of providers voluntarily found spending restraint within their own budgets to help begin to slow the growth in Medicaid. But I think it's important to understand that we're not cutting Medicaid. We're simply slowing the growth. The growth in Medicaid could have been as high as 13% without these actions, but now it's around 4% and slightly less. But there's a number of things coming up that we'll talk about in a bit that could add to those costs in the future. Basically, the Medicaid Redesign team's final year of work it led to a number of work groups discussing a number of major steps that needed to be taken in Medicaid to reach what's called the triple aim. I think you all know about this. It includes reducing costs, improving patient care and supports, and improving health outcomes. Basically, the final report of the Medicaid Redesign team was turned into an extension, a 5-year extension of a major waiver to the Centers on Medicare and Medicaid Services to expand what had been New York's managed care waiver in existence called the Partnership Plan. It is basically a very bold and robust effort. You can see what we're asking of the federal government here. We're really asking that we believe that the savings in Medicaid from the steps that the Medicaid Redesign team is proposing will save over $17 billion for the federal government over 5 years. And we're asking the federal government to reinvest $10 billion of those dollars back into New York for a whole host of investments in better and improved health care. Still leaving and meeting the cost neutrality issues that one has to do with the waiver process with the Fed, still leaving about $7 billion in federal savings. It's one of the largest waiver requests ever made to the Centers for Medicare and Medicaid Services. It has multiple components. I would ask you to take a look. It's by no means a done deal. It has a lot of high risks to many aspects of it. It's asking, in some cases, for Medicaid to spend dollars on issues it's never traditionally spent dollars on. And it's going to take quite a negotiation with the federal government to see it through, either partially or fully. But it is an important approach. The full request of the $10 billion in reinvestments is outlined in the paper on page 4. You can see exactly what, without going into them, exactly what's being proposed to invest in. And there's a discussion about all of the, the other hurdles with Medicaid that are going on at the same time this waiver is being requested in Appendix A of the program. Now we really want to get to the gist of what we've been talking about in this paper, and that's the issue of taking some lessons, as Paul said, from welfare reform, particularly around incentives, taking some lessons from the whole field of behavioral economics as to what motivates people to do the right things, and basically saying that if you don't take the other part of the equation, which is the Medicaid patient, and have ways to cajole, urge, help them do the right things as far as practice healthy behaviors, and have expectations of them to practice healthy behaviors, all the kind of supports in the world probably are not going to make the day. New York has a robust system of patient supports. The program is moving towards care management for all. We're looking at primary care health homes as a place where people will have a place where they'll have multiple issues coordinated by a central care coordinator. We have nurse home visiting programs. We have health navigators that help people navigate the system. We use peer counseling throughout the mental health and other worlds. We use a great deal of patient education. We have facilitated enrollers in Medicaid who help people sign up and understand the program. We have 24-hour helplines. We're investing heavily in supportive housing, particularly for very high-risk chronic need patients, to try to centralize their care and get them in a supportive housing framework. But with all that in place, patients need to play a role when supports and care management and all those things are in place. And the way to get that done, from our perspective, is through a series of incentives that encourage healthy behavior, and ultimately through some requirements that patients actually follow medical treatment plans, follow medical regimens, and take some more ownership over their own care. The field of incentives is a growing field. We use incentives in many, many things. And you'll see from this slide, we were going to talk a little bit, as the rest of the time of my time, about some things that are happening in 5 or 6 places from which we can learn and borrow ideas. Not only have states that you see listed here done many things to use incentives, but insurers, CDPHP here in the Capital District, Emblem Health, United Healthcare, the Monroe Health Plan, and many others offer cash or cash-like benefits to their employees and to their managed care plan participants to try to get them to do the right thing as far as preventive health and healthy behaviors. Employers also are consistently using incentives more and more. AmeriGas, Safeway, IBM, North Shore Long Island Jewish, one of the largest health providers in the state, offer incentives usually in the form of reduced premiums to their employees for following healthy behavior patterns. And there's a growing but small evidence-based experimentation models out there that show us that you can improve health outcomes and save money by using incentives. So what generally are incentives that are used? Well, there's really about 4. Basically, the most important one that's been experimented with in a number of these states are what are called conditional cash transfers, which basically says we will give you a cash or cash equivalent payment in return for you doing certain things that are expected of you in the healthcare world, to take ownership of your care and to practice healthy behavior. The second one is often enhanced health benefit packages that wouldn't be available under a traditional Medicaid program, but would be benefits that would go to people who are practicing healthy behavior, often things like wellness classes, fitness classes, nutrition counseling, tobacco cessation, weight control, many different things. And those are enhanced benefits usually provided for free, but with the expectation that they'll actually be used. And then there are a whole growing number of sort of health insurance ownership programs, one of which we'll talk about in a bit in Indiana, which use health savings accounts, give people a fixed sum of dollars with which to pursue the health care needs in a given year, with the expectation that certain services will be free up front and that they will be a more cost-conscious consumer by virtue of having their own money to manage. One of the things I think is very important to understand is there's been some studies done of these incentive programs about how effective they are. One major one at the University of Minnesota by Robert Kane looked at 111 different experiments in the healthcare area, winnowed out 47 of them that seemed to meet a model for a research design, and found startlingly that 73% of the time the incentives worked to help people afford preventive care that they might not have others sought or would have postponed. And it worked not only for just simple things that, as you would assume, like well-child visits, immunizations, but it also worked to change more complex sustained behaviors almost 72% of the time. And that's one of the largest studies that's been done empirically about how incentives can work when they're well designed and well thought out. I think one of the points of the paper here is that New York's embarking on some modest efforts, but we really need to do more, and more needs to be done nationwide, because the more experimentation we have, the more chance we have to see what works, flexibly design and change things that aren't working, and bring other efforts to scale that are working well. Let's look at a few things that have already occurred. Right in New York City, as many of you know, Mayor Bloomberg introduced several years ago a program called Opportunity New York City Family Rewards Program. It basically was a random assignment program that allowed people, and it looked at several different areas, in the area of education, in the area of health, in the area of poverty reduction, and gave people cash incentives to pursue certain different behaviors. This slide shows simply the level of incentives provided for people to do different things in the health arena, ranging anywhere from $100 to $600 in incentives for people to pursue basic preventive care. Some have opined that Opportunity New York City, which was evaluated by MDRC and is still being evaluated, was a failure on some levels, but actually in the healthcare area, the findings are actually fairly impressive. You can look at Appendix B of the report as well for a much more detailed description of Opportunity NYC. But basically, 3 findings. It increased the maintenance of health insurance for families because of the incentives. It increased the use of preventive dental care. and it reduced emergency care use, and it reduced unmet health care needs that were usually postponed due to prohibitive costs. So I think there's great promise to be learned from the Opportunity NYC program. Another effort is in Florida. This was an enhanced benefit program. You can read about this on page 16 in the report. What it basically was part of broader Medicaid reform. It started out with fits and starts, as some of these programs often do in the design phase. It basically offered up to $125 for various behaviors, keeping appointments, getting necessary screening, following disease management plans. And it was flexible enough, as you can see from this slide, to take what had been an early lackluster start where people didn't understand the program as well, they didn't understand the enhanced benefits, and didn't claim a lot of the credits available to them. But that changed over the 6 years of the program to the fact that nearly $54 million in credits had been redeemed, and $54 million had been earned and $30 million redeemed in 2012. The Florida Advanced Benefits Program is still being evaluated, and there'll be further learning from that as we go forward. The state of Idaho, which clearly is not New York, one of the least populous states in the nation, but nevertheless embarked on two interesting programs called Idaho Wellness. They were both based on recipients of the services providing modest premiums based on, you see a model here. What they did is between certain income levels, they paid a monthly premium adding to an annual premium of $120, and then some paid $15 monthly and $180. Basically, in return for those premiums, they they had to sign a membership pledge to meet certain issues around weight control, exercise, quitting smoking, and so forth. And for the children, particularly the preventive avenue for children, it was, again, child wellness, immunizations, well child visits, and there actually was some very good points were awarded for meeting these behavioral goals, and the points were used to offset the premium costs. So basically, what happened when you earned the points and you stayed current with your with the regimen that had been prescribed, you offset those premium costs either fully or by 2/3. The theory here being, again, that the incentive was to seek the available and required healthy benefit programs in order not to have to pay the premium. And what they found, the Urban Institute has evaluated the program. More than 20,000 children earned compliance points, offsetting almost $1.5 million in premiums, and only 1% or 100 children did not secure those offsets in the well child version. So basically, I think it demonstrated pretty clearly that that people will comply with expectations when indeed the reward is that you've put some money out first and then you get that money back by complying. So the Idaho program also shows promise. The West Virginia Mountain Health Plus program is another one that looked at this same kind of approach, basically, and you can see that the results from the slides here are that adults enrolled in the plan visited their doctor twice as much and children 60% more frequently because of the incentives and so forth. But in fact, again, programs as they're constructed need to be thoughtful and well designed, and the West Virginia program, unfortunately, was not that thoughtful or well designed. And enrollment was very low, and as you can see from those factors included poor marketing and a general misunderstanding of how the program worked. In simplicity, the program worked that someone who enrolled came in and signed a pledge in their health home in front of their care coordinator, pledging to adhere to treatment plans, take their prescribed meds, and limit their use of the ER. In return, they got enhanced benefits not available under traditional Medicaid, ones we talked about earlier, particularly the tobacco cessation, weight counseling, cardiopulmonary rehab, nutrition education, etc. Those not signing up got regular Medicaid. A survey found the plan increased the use of primary preventive care visits to physicians by both adults and children. Unfortunately, West Virginia was planning to address the inefficiencies in this program as Florida had done and try to maximize it and make it better. Unfortunately, though, CMS pulled the plug on the program by saying that they couldn't offer differing value Medicaid plans to children. Just quickly, the Healthy Indiana Plan is another one that was one of the first programs based almost exclusively around a consumer-driven plan with more patient control. It relied on a health savings account. It was available to people under 200% of poverty, not eligible for Medicaid, or not accessing employer-based coverage. The power account that they got, which was a savings account, basically was $1,100, for which they paid part of that account up to only no more than 5% of their gross income. And then, and then the state would subsidize, or nonprofits would subsidize the rest of it. The program has been a success, and Governor Daniels, who recently left, was going to use the program as the basis to expand Medicaid under the Affordable Care Act. But again, CMS has scuttled the program and only offered a 1-year extension when they had requested a 3-year extension. But you can see that the results from the health savings account and the incentives were really quite good. And so we'll see where Indiana goes from there. I know I don't have that much time, so I'm going to try to wind up with just giving you some sense of how incentives can work. Obviously, the first underpinning is that you really do have to have that primary care capacity and those patient supports in place as well, because if people don't really have preventive settings to go to, then all of the incentives in the world aren't going to make that much of a difference. Incentives have to have, and requirements have to have unambiguous terms, which means they have to be very clear to the recipient as to what you're earning an incentive for, how you earn it, exactly what you need to do to earn it. And if you have requirements imposed on you of things that you must do in order to earn the incentive, it must be clear what happens when you don't meet those requirements. Patient education and outreach is a fairly obvious issue that needs to be done throughout. Programs need to be evaluated rapidly because we don't want to spend a lot of time on frivolous programs that don't work, but we want to scale up the other ones that do, and they need to be flexible. New York is taking one very positive step that I wanted to talk about. Basically, New York is a grantee in a program called the Medicaid Incentives for the Prevention of Chronic Disease, an $85 million federal program over 5 years, established by CMS. You will see, you know, in the paper, you can find in the middle of the binding, there's an outline of what the 10 states are doing. Again, the traditional sort of things aimed at diabetes, weight control, obesity, a whole host of issues. Direct payments of up to $250 a year for certain habits. Again, a random assignment program, 3 incentive groups, 1 control group. The program was meant to begin in 2011, but unfortunately, the Department of Health has a second request for proposals out for a vendor to implement the incentive program, and so it has been stalled and not yet implemented. Lessons from TANF. What I really want to say here, so there's no misunderstanding, is that TANF was really an incentive-based program to a great deal. I mean, most people look at the fact that TANF said if you don't meet work requirements, certain things will happen to you, including you may lose a portion of your grant or other things of that nature. But what people don't seem to understand is TANF relied greatly on things like earnings disregards. In other words, if you go to work, you'll get to keep more of your welfare benefits until you reach a level near poverty and income. It also provided child care, case managers, a whole host of supports to the TANF client. I'm not talking about an analogy here to TANF to reduce caseload, because I think that's a bad idea, or take away health coverage, because that's counterintuitive to trying to make things work. But really talking about the sort of leverage and philosophical issues that we can learn from TANF as to how to encourage and require people to take more ownership of their care. One interesting concept that could be tested, and I know it would be very controversial, but since there is such a crossover between TANF and food stamps and Medicaid receipt, that for people who are expected to do certain things, we could test through multiple federal waivers that would be required, whether withholding a portion of food stamps or their TANF grant would indeed prompt recalcitrant people to seek more and require them to seek more preventive care. Recommendations we'll close with. Introduce conditional cash transfer rewards, the kind of things we've been talking about, payments for enrolling in fitness, payments for buying disease-related pharmaceutical products, etc. One of the things in New York that's troubling for insurance plans, for managed care plans, is they're limited in what they can offer as incentives to their Medicaid clientele. They can only offer $75 under state contract language. And that seems to minimize the ability of some of these plans that would like to do more but can't because the incentive isn't thought to be large enough to prompt a behavior of change of the kind that would be desired. Incorporate healthy behavior agreements. These are the kind of things like pledges, mandatory participation in wellness programs, and modest co-payments for the inappropriate ER utilization, among other requirements for patients. At the federal level, the Medicaid Incentives for Prevention of Chronic Disease is really a pittance when you think about it. Medicaid's overall budget is $383 billion federally, and only $85 million of it has been awarded to 10 states to pursue these incentive programs. It's not really enough to get a full field and a full scope of experience to weigh and to evaluate. And finally, the federal government really should stop impeding the testing of individually designed state incentive and responsibility programs, as they've done in both West Virginia and Indiana, by taking what were very promising approaches and in effect scuttling them, apparently mostly on ideological grounds rather than on the grounds that the programs weren't working. The last thing that we always talk about and that Paul and I have written about is that for the longer term, and these are just issues to ponder, they're not really discussed greatly in the paper, but there may be more need for Medicaid reform in the future, particularly with its tandem interaction with the Affordable Care Act, to think about converting it from a defined benefit plan to a defined contribution plan, allowing Medicaid recipients to opt out and use other health insurance exchanges or other comparable subsidized private coverage. Experimenting, as the state of Rhode Island did recently, with a pure capitated dollar figure for all Medicaid expenditures in return for less federal intrusion regarding program operation and flexibility. And finally, as you know, there's a great deal of discussion about the possibility of Medicaid block grants in the future. One can have very polarized opinions on that, and certainly there would have to be protections for medical growth and inflation and other things of that nature, but the federal waiver process is so convoluted and complex, and states have become very sophisticated, as this state has, in managing their Medicaid programs, and frankly might do better under that kind of an environment. So that's what I really wanted to talk about today, and turn it over to our good panel to agree and disagree with certain of these points, and really appreciate you all attending. Thanks.